Thank you. This is the third. We have a series on this subject, and this is the third, and I believe is the last one to talk about spirituality and mental health from this series. And so the first two workshops that we did, the first one was we talked about assessment from the clinical perspective. We tried to assess where the assess their spirituality. So before we do anything, do the assessment, I like to, we talked about the what does spirituality mean to us, because we are spiritual beings, and understand what spirituality mean to you and what spirituality mean to your client is important. Kind of create that space. Also, we talked about how to approach spirituality with your clients and approach it with this is something that from Dr. Dan Siegel from UCLA, COAL, approach it with curiosity, openness, acceptance, and love, and try to build different perspectives with your clients, because my perspective of reality, of spirituality and religion may be different from my client. So it's important to have that curiosity with love and acceptance. And then we also, during the first workshop, we talk about spiritual assessments. We have 6 assessment scales and inventories that we talked about during the workshop. I believe it's also available. Maybe we can send those out to send those out at the end of the workshop after this workshop. And there's different way of do assessment. We can do it implicitly or we can do it explicitly. Like for explicitly, we can use the scales and the inventories. However, it's very important to do the implicit assessment. Like we talk about, listen to the spiritual language of the client. For instance, some client, they call my spirit, they call their spirituality like the presence, the hands that protect me, my dove, some being beyond my understanding. So it's important to allow the clients to name their spiritual beings. Sometimes a present we call God, it may be a different, they may name it differently. For instance, I come from my background is Christian. So even within Christianity, I have seen my clients call their spiritual being, God. They call the presence. I have seen them call truth. I have seen them call my Lord. So allow your clients name their spiritual being, their spirituality, basically. So it's good to ask your client, how do you name your spirituality? How do you name that presence? And then use that, because each of us, there's a certain term that we feel closer to, and that's important to honor that. Can I have the next slide? Yeah. So this slide provided by Bill, and I find it very important for us to keep in mind. Our goal should be to live life in a radical amazement, get up in the morning and look at the world in a way that takes nothing for granted. Everything is phenomenal. Everything is incredible. Never treat life casually. To be spiritual is to be amazed. And we can bring this into the clinical space as well. To be spiritual is to be amazed. Sometimes it's good for us to be as an observer, to be amazed at your client's spirituality. And that's very important. Can I have the next slide? I know I'm going to get 3 minutes left. But in integrating spirituality into your work is first you kind of do the assessment, where they find their spirituality. Some people, they find it like watching their, watching doves, doing gardening, taking walks. So each of us, spirituality is not so much about religion, or it's not so much about a set of beliefs, but it's about how does that person find things that help them feel grounded, being present to themselves. So in the second workshop, we talked about these 9 points in integrating spirituality into your clinical practice. Is to respectfully assess the client's religious beliefs, preferences. We had talked about just that. And also sometimes our spirituality beliefs may contradict or may we feel like, let me see, how do I say this? May like contradict with the client's spirituality beliefs, right? It's good for us to separate that. There's nothing wrong with that. They could be different, but there's no right and wrong. And it's good for us to understand our countertransferences. And sometimes we don't need to know all of these set of beliefs out there. It's good to learn from the clients. What is their set of beliefs? How do they practice their religion? I talk about death with my clients because that's an important part. In your beliefs, what death means. For Christianity, there's an afterlife, right? And and then how does that afterlife look like? So I allow myself to learn from my clients on learning more about their beliefs, what life means, what birth means, what lives mean, what death means. That's very important. And also it's important to understand how do they is there connection between their mental health and their beliefs. For instance, talk about suicide, right? With the Christianity, that's something against the teaching. I don't put it like right or wrong. I just kind of understand their perspectives, how they connect it, how does it implicate their symptoms. It's good to kind of hold the space. Be an observer. Don't need to make any decision. Don't need to do any evaluation, but try to be observed and make connection. It's good to consult with experts in the field. NAMI is a good source for clinicians to understand the implication of faith, communities, spirituality, beliefs. And there's other places, for instance, your community of faith. It's good to understand that part. So that way it's part of competence, right? As a clinician, I'm more speaking on the clinician side than anything else right now. And then allow your, and I think this is the most important part, is actually allow your clients to lead you, allow your clients to teach you, allow your clients to 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 uh, to lead the sessions in terms of spirituality. I think that's the important part. So I just want to make a summary from the first session to the second session. The first session was like assessment, know your counter transferences, and then the second was more how to integrate. Thank you. I believe this is the next session, next presentation.
Wes, you're muted.
I will introduce Dr. Rania Awad. I have seen her separately on 2 different occasions speak to a spirituality and mental health group, and I was so impressed with her talks, and I learned so much, and I hope you will also learn. But I'm going to introduce all of her credentials, and I have to read it because there are so many. So here it goes. Dr. Rania Awad, MD, is a clinical associate professor of psychiatry at the Stanford University School of Medicine, where she is the director of Stanford Muslim Mental Health and Islamic Psychology Lab. She's associate chief of the Division of Public Mental Health and Population Sciences and co-chief of the Diversity and Cultural Mental Health section. She is also the executive director of Meristan, a nonprofit organization dedicated to reviving the Islamic heritage of holistic well-being. She is currently a senior fellow at Yaqeen Institute and ISPU, which stands for Institute for Social Policy and Understanding. In addition, she serves as the director of the Rama Foundation, a nonprofit organization dedicated to educating Muslim women and girls. She has previously served as the founding clinical director of the Khalil Center, San Francisco, as well as a professor of Islamic law at Zaytuna College. Prior to studying medicine, she pursued classical Islamic studies in Damascus, Syria, and holds certifications, Ijaza in Quran, Islamic law, and other branches of Islamic scientists. Follow her at Dr. Rania Ariana Awad. She is an MD and director of Stanford Muslim Mental Health and Psychology Lab, and she also is married with 3 children. Whew, that's a lot. And it is my honor to introduce her. Dr. Awad.
Hello, everybody. That was really funny. Thank you, Wes. I appreciate being here. Thank you for the invitation. Wonderful to spend some time with you today. I'm really looking forward to this conversation. It's one that I'm very passionate about, kind of bringing really my 2 worlds together, kind of being a faith leader and a mental health professional together. And here we have an audience of both mental health professionals and faith leaders. So it's really just a wonderful topic, and I'm really happy to be here with you for it. I'm going to share, I can't quite share my screen, but if I can have the share privileges, I'd like to share some slides with you, if that's okay. Whenever that's possible. I can start talking though until that happens. If our moderator can give me share privileges, thank you. Because today we're going to, and I really love, by the way, the title of the topic of All Hands on Deck, which is really how, exactly how I really think about this topic, where it really does require us to fully understand that, holistic wellness all the way through is not going to happen unless all of us are really helping and realizing what kind of overlaps there are, but also realizing where the limits and barriers to those overlaps are. So here's our conversation for today. And I understand after this, there'll be some breakout groups, and I'm happy to take questions, of course, either during or at the end. So I'll make sure to have my chat box open in case you have a question you'd like to put in there. I'll try to keep tabs on that. All right, so as we kind of look in here, first really discussing kind of faith leaders and mental health clinicians, the overlapping roles and responsibilities, because there really are a number of them. And if we look at what these are, you'll see that there's common goals that we share. Promoting health, healing, wholeness is something both professions and groups of people do. Where the comment on the side here that says, people that experience mental health conditions first turn to their faith leader. This is true of so many different faith traditions. I know in the research that I do in the Muslim community, this is still very much accurate. It is changing, interestingly enough, where some of the stigma around mental health is starting to be reduced and people consider going to a mental health professional first. But by and large, every time we do a survey or a study on this topic, the faith leader, it comes up well before the mental health professionals as to who people from faith communities will turn to. Usually it's family and friends first, then it's the faith leader. And this is why it's really important to see that from our perspective, as now I'm speaking as a mental health clinician, to say it is really vital to actually bring in our faith leaders into the fold in terms of mental health discussions, because as long as we're able to foster those respectful and collaborative relationships, it really does improve the quality of care for the individuals who come from faith communities, right? And so from a public health perspective, I could definitely tell you that we consider our community leaders, our faith leaders, as gatekeepers, as our first responders, whenever there's a mental health problem, a substance abuse problem. And they really can help dispel the misunderstandings. They can really help reduce those stigmas by actually kind of giving their blessing, so to say, right? Even on discussing this very topic, even broaching it or having programming about it in their center, religious centers, and could really be a way to break that stigma. Now, if that's what the mental health providers, if that's what the faith leaders need to do, kind of increase kind of their understanding of the best evidence-based treatments, what are the psychiatrists and mental health community, what do they need to do? What they need to do is really understand to loop in our spiritual leaders, our faith leaders, and to increase an understanding and respect for that role. And really, if the two worlds kind of came a little bit closer together, I think we'd have a much, much better chance. So this is a diagram that SAMHSA is available on SAMHSA's site. And I really liked it because it talks about all the different facets of wellness. Sometimes when we think about wellness, we think of mental health or emotional health. But actually, it's actually a number of different facets. And you see these overlapping circles in this diagram. And this, to me, is what I refer to as kind of a holistic understanding of mental health. You look at emotional aspects, right? But then there's also environmental, how people are doing with the environment that they're currently in. Social is connected to that, but so is financial, physical, intellectual, occupational, and definitely spiritual. When you look at all these different facets, you realize that if any one of them is off, or if a couple of them, or a few of them, and if COVID-19 or this pandemic has taught us anything, it's that any one of these circles can get shifted out of place really quickly. And when they do, it really does throw off a person's wellness and overall ability to be resilient to what's coming their way, which is why the more of these aspects we can consider in the work that we do together, the more important and better outcome it'll be. Now, when I think about holistic wellness, kind of this whole person approach, as we call it, there's a couple of different things to take into account. First, when we talk about wellness, we mean overall well-being, kind of like the diagram on the previous page. And to realize that people that have mental health and substance abuse conditions, it's not just simply the absence of the disease or the illness or even the stress. It's actually sometimes when we talk about their well-being is impacted, it could also be the lack of purpose in life. It doesn't have to be that they have a diagnosable condition. It could be that they're not satisfied actually with their work or their relationships or their own health, right? All of these kind of lead to a sense of well-being. And when they're altered, they also alter wellness. So when we think about kind of mental, emotional, physical, occupational, intellectual, spiritual, all of those different facets, we're able to then really start to understand what that overall well-being really means. So here starts the conversation, and I'm going to direct the first half of my comments here to our faith leaders and our mental health clinicians. You're next. So don't feel like the conversation's just to our faith leaders. You're coming right up after this. But really, when you think about now addressing kind of faith communities, how our congregations could actually be more inclusive and welcoming, there's a couple of really important aspects to this. One is learning about mental illness. When we identify the myths and stigma in open conversations, people are more likely to come up when they find that we are open, when we lead by example. Sometimes that means, and one time I had a training of all, they were all faith leaders of different faith traditions. This is pre-COVID. It was wonderful actually, and it was, so many people from different faith traditions were there, and we talked about this concept of leading by example and what that meant for certain people. Certain of the pastors or certain of the ministers were able to say, "Hey, I go to therapy," right? Sometimes if it's too much to even disclose that, sometimes it's just enough to even say therapy works or can be helpful, right? Just that permission essentially is sometimes what people are waiting for. They're kind of wondering, is it even okay? Would it be, does it mean, and we'll talk about this on an upcoming slide, does it mean that my faith is not fully intact if I'm needing to go to therapy and not just rely on faith, right? So hearing these words from a faith leader can be majorly impactful, right? It also means giving workshops or sermons, hosting lectures about mental health and mental well-being, bringing in a mental health professional into the congregation space is very useful. I remember years ago in one of our Muslim community partners in Santa Clara, we, this is, I don't know, must be definitely over a decade, maybe closer to 15 years ago, we tried to have a group of people tried to have a substance abuse workshop at the mosque. And they actually called it exactly those words. One person showed up. One person. And then they were literally like, recruiting people from the hallway, like, come on in, come on in. It was really, really difficult to even have that conversation. There was so much stigma around it. Nobody wanted to be the ones, the person seen in that room, in that workshop. And so I fast forward to now, where just the mere fact of having those workshops, even though nobody came in that very first iterations of them in the mosque, having these topics that say on the mental health or something about well-being or something about emotional well-being, always tying it with the spiritual aspect, but having that piece to it over the years have meant that people have been much more receptive. And now I look at, whole mental health conferences that happen within these, religious spaces, faith-based spaces. And it's really heartwarming because we've come such a long way. But it took persistent programming, even when people at first were not able or willing to join, right? What else? Creating that welcoming environment, right? Mental illness could be very isolating for so many people and their families, right? Which is what NAMI is all about, right? And ensuring that they feel welcome in all aspects of our community's spiritual life is really important too. There's always room, right, in our congregations for all people from all different backgrounds. And that also means folks that have, mental health or even serious mental health conditions. Just figuring out how to do that exactly might take some planning and discussion, right, with those who are in the leadership of that spiritual space. But I think it's really important that inclusiveness helps quite a bit. Right? It also signals to others that I can bring my other family members or even myself if one day I'm feeling this way too. Right? That I don't need to isolate and stay away because everybody at church or the mosque or the temple is perfect and I'm not. What else? Getting trained. encouraging our faith leaders, our imams, rabbis, priests, and other forms of clergy, and also our lay leaders, our community leaders that are not directly have titles, religious titles, but are definitely leaders in the community, to have kind of the mental health first aid training, which I know there's been a few sponsored already with this organization, which is really great, but also custom tailored trainings. In an upcoming slide, I'm going to talk about a difficult topic. It's the topic of suicide and some of the work we've been doing actually on this topic in the Muslim community. And we actually have an upcoming training in a couple of weekends from now. We spent like almost 5 years developing this very custom tailored training to this specific faith community, the Muslim community. And, the number of faith leaders who in the aftermath of an unfortunate aftermath of a death by suicide, say, I don't even know what to say. Like, I'm so lost for words on how to really comfort the family, because there's also some theological, barriers on what can be said and how it's said and so on in certain faith traditions. And so it becomes even more vital that these trainings are had, right? Because again, our faith leaders are often the ones who are right at the front lines within a faith community. What else? Having an inventory of resources. This is important. Now, I've been part of groups that have put together lists and said, here's a list of mental health providers and organizations you can refer to. Here are ones that take Medi-Cal and ones that take insurance and ones that take, sliding scale resources and so on and so forth. And we have been somewhat successful in getting some of these lists, to faith leaders, and some of whom have been very receptive to it and very happy with it. We've had other experiences where a faith leader has said, thanks, but no thanks, right? And kind of locked the list away in their drawer and said, I've been a faith leader all these years. What do I need this for? And it's heartbreaking, honestly, when that happens. But you would hope that the next, no one stays in that position of leadership forever, right? And so you would hope that the next generations, if you will, of leadership will be more open. Sometimes these resources are available, and I have some at the very end of my presentation here to share with you. But sometimes it requires the congregation, the leaders within that congregation, to actually put the list together themselves, to spend some time doing this, actually dedicate, a work group to make this happen. And it could be custom tailored to the specific faith tradition, or it could be more open, broader than that. But it's really important that it's there, because when a crisis happens, it's just sudden. You can't at that moment create the list of inventories, right? So that's, just things to take into account to help be more inclusive and welcoming. Now, a couple of words on mental illness and faith in general. When I think about this, I think about the different perspectives that various faiths have related to mental illness. And this slide is not specific to any one religion or faith. It's kind of a broader concept. And different faiths have different, iterations of this. But some consider mental illnesses to be a spiritual disease. And therefore, they're kind of looking to prayer and other forms of religious healing. Whereas others think about it more as a supernatural explanation, right? There are definitely members of various faith groups that do consider that there is some sort of supernatural phenomenon that may explain what is happening to a person with a mental illness. Then, of course, there's the biological, physiological, psychological, environmental kind of theories. In our field, we like to say mental illness is multifactorial, meaning it's all of the above, potentially. It could be any combination of the above, potentially. And I think the broader we're able to think about this, the better. And the more buy-in we get from our congregants, from the people that we serve. Because it might be that in their frame of mind, there is, in fact, a spiritual or supernatural explanation. And what I do as a clinician, now speaking now as a clinician, I try to explain the broader theories that there could be multiple things potentially happening, and I don't ever dismiss any one thing. Because I simply don't know. Could it be that there is a supernatural explanation to some of what's happening too? Possibly. But if the criteria also meets a clinical condition, then it's incumbent on me to be able to say that clearly as a clinician as well. Now, for those here who are not clinicians, we'll talk about the importance of referring to the clinicians, right? In times where you say, I reached my knowledge limit and it's time to talk to the professionals. When we think about different perspectives that people have on the purpose of mental illness, you hear everything from it's a test or trial from God, or this God is sending me this tribulation in order to expiate my sins. You hear things like mercy, also reminders or punishments, opportunities for forgiveness or for turning to God, spiritual growth, purification. I've heard all of the above. I wonder how many folks here have heard different renditions of these explanations around mental illness. I think they're pretty common. They differ, of course, from one faith group to another, but by and large, these are many of the perspectives people have. Now, the part that's important in this story, these are all important points, but what's really important here is when we confuse the mental health and the spiritual health pieces together. And I think that, the next box here talks about distinguishing one from another. And it's hard because they're inextricably intertwined. They really are. I mean, it's really hard to say to somebody of faith and to say to them, no, that's purely a mental health issue and that's purely a spiritual issue. Often they're very much intertwined. And even if a person has understood they have a clinical condition, let's say they meet all the criteria for major depressive disorder, for example, they may have distressing spiritual concerns too. Like, does this mean God has forsaken me? Or why doesn't God heal me, right? Or like I mentioned earlier, if I take a medication for this, does it mean my faith isn't strong enough? So sometimes they're so overlapping that it's really hard to get full buy-in or full treatment planning if there isn't that spiritual aspect taken into consideration. And vice versa, right? And opposite is exactly true. It is really hard to get buy-in to understand the medical or biological aspects of this if the viewpoint is purely only spiritual, right? So we have a lot of work cut out for us. Right? We have a lot of work cut out for us together. And here are some of my tips for how do you distinguish these conditions one from another, and how can we best help? Boundaries are really useful. This is where we talk about, and people sometimes do not like the term I'm going to use, but I think it's an important term. And it talks about, when we drive, we have the rules of driving and we each stay within our own lanes. And if we didn't, and we start to swerve into other lanes, we cause a lot of problems. And part of that is understanding what are the guidelines for pastoral care and counseling, spiritual counseling. And where does the line get drawn between that and actual professional psychological counseling, right? My encouragement here is that every, religious institution actually create, if they don't already have them, or refer to, because a lot of times these guidelines are actually already available for certain denominations, and to have these policies in place and then implement them, right? What is that limit? Where do you draw that line? Also taking really good care with language. Sometimes mental health conditions, especially with people of faith and religion, they express it in this very kind of spiritual language where for a faith leader, we may hear these words and think, oh, this is a spiritual issue. A person's going through a spiritual crisis because they might talk about unpardonable sin, or this is a family issue, or they're distressed that might, hey, imam or priest, my prayer is not being answered. And that's what it sounds like. That's what they're saying. But we may need to do the translation over of, could this be more than just the prayers are not being answered? Could this be somebody kind of reaching a point of hopelessness and helplessness that it may actually not only be a mental health condition, but and a spiritual crisis, but actually might end up being an urgent case where we need to immediately refer, like the next box says. So anytime there's a sense of kind of despondency or an impulse to self-harm or suicidal intent or behavior, right? We have to be really careful not to couch this in spiritual language and try to deal with it ourselves as spiritual leaders. Rather, there needs to be this immediate referral to clinical care professionals. And if somebody uses the words directly, like suicide or I will kill myself, I mean, sometimes it's very obvious, but sometimes it's not quite as obvious. And there needs to be a little bit more digging and asking. And that's where the last box here speaks to kind of resisting that premature understanding, like what we have this word in our field that we call spiritual bypassing. And what it means, and this is done often by people of faith communities, where they will explain sometimes very serious conditions in spiritual language. And so they'll just sort of bypass and they'll say something like, God is great, all is good, right? All good comes from God, various renditions of this. And they'll kind of pass over what's actually very serious and potentially a mental health problem. So the recommendation here is, if after 4 to 6 sessions of spiritual counseling, you find, and this is kind of a rough estimate, 4 to 6, right? But you find that the issues are still persisting and your congregant is exhibiting kind of a sense of hopelessness, or there are areas of their life where there's some dysfunction, right? This is where the referral, because sometimes people say, I don't know exactly when to refer to mental health professionals. If it's a real crisis like the top box, great, I understand that that's an immediate referral. But what about if it seems kind of lukewarm? How do I know when exactly to refer? So our recommendation here, and this is actually a recommendation I took, a lot of this presentation is coming from a guidebook that I'll give you the link to, developed by the APA, the American Psychiatric Association, on faith leaders and mental health. And this was a recommendation that after some time they kind of came to, which is, the 4 to 6 spiritual counseling sessions. If a person is really still having that sense of hopelessness and dysfunction, this is where the clinical referral to a clinical professional really needs to happen, so that they can do the diagnosis and assessment. It's not, the burden is not on you, right? And treatment, but it's with ongoing support from you as the faith leader. And that last part is really important, because often people want their faith leaders still involved. Right? And in my practice, personally, I very much want that. Now, the referrals need to be communicated clearly, right? And I put here some sample language, things like, let us think together about the help and resources that will be most of value to you. Or any rendition. I mean, you're in your own words, right? You're speaking from the heart here, but it's a clear referral, right? And there's a clear difference between that spiritual support and professional clinical care that you're explaining to your congregant. And you're reassuring them that you're going to journey with them. You'll be there with them through this entire journey. And that usually is very helpful, because it reduces the fears, the stigma, religious misunderstandings that often keep people. They're often barriers. And they're all misunderstandings, right? And so you can really be the person that untangles that for someone. Also, economic challenges. That's a very real thing. We know this about mental health in America. It's not cheap and it's not easy to get to. And so asking direct questions about their medical insurance helps, because then you were able to remember the resource inventory we talked about on the previous slide. You're able to say, okay, this is Medi-Cal, let's go down that route, or this is private insurance, or this is a sliding scale situation, right? And yes, it may seem like a little TMI, right? Too much information for you to know, but it's actually very helpful, because you might be the person that kickstarts your congregate to getting the help and care. So not too invasive, but just enough to help you figure out what resources to help them with or to send their way. So we talked about the resources and then follow up. The last part is the follow up. Now, remaining connected to see how the situation evolves is going to be really important. I find people say often that they're really thankful that somebody kind of set them on the path for help or recovery, but there just wasn't the follow-up. Nobody went to see, hey, are you still doing okay? Are you hanging in? And that's one thing where religious and faith groups and congregations are really, really useful, actually. It's the follow-up. And if someone's gone for a while from the congregation, it would be really important to see, hey, what happened to them? Sometimes they just moved on, or they found a different, group to be with. But sometimes it's just a matter of they've become more isolated, or they're in the midst of their recovery or help, and feel that they're not able to reintegrate back into that original congregation they were part of because nobody actually asked about them or checked in on them. Right? So those are all things to consider here. I really like this statement, and I hope it's something that we can, anything we take away today, I hope we take away this one. That the person has an illness, but the person is not the illness, right? That's really, really key. And reminding a congregant that you're working with this statement is really key as well, that they have an illness. Many of us have multiple different medical conditions, right? Potentially. But we are not the illness in and of itself. We are not the problem, right? And so that helps people acknowledge that they have a medical condition, potentially, right? A mental health condition. It helps reduce the stigma. It also is really useful to talk to people who you find really resistant to accepting medication. You know that they need to get help, or just even just therapy, just getting help, right? Sometimes it's useful to understand their past treatment. Like, have you gone to therapy and it hasn't worked before? That might reveal a lot right there. Have you tried medication that hasn't worked, which is very, very common with psychiatric medications. Usually it takes a lot of tries, a lot of trial and error until the right medication clicks and fits, right? And it's a pain, honestly, it really is. But when the person is on the right dosage and right medications, they'll tell you it's a world of a difference, like night and day, right? So it's worth the trial and error, but kind of even just letting people know that may happen so that they're psychologically prepared for that could be very useful. Right? Having a support team, and a team of people, different people they can turn to, right, when they need help, not just one person, because burnout amongst our clergy is very, very real. Right? And then religious concepts. Remember, I talked about the various ways people describe difficulties that they're having. And you could play an immense role in kind of helping them distinguish one thing from another, right? And understanding that if the theological belief in that faith tradition is all things good and bad come from God, then it's like, yes, now let's kind of distinguish what is medical potentially and what is spiritual. And addressing sense of hopelessness. Religion and faith is so excellent with this. It is one of the main sources of resilience. Every time we've done a research study on faith populations in our lab, we work a lot with the Muslim population, and we ask, I'll give you an example of this. We had a very, very large study on COVID-19 and Muslims. It was a global study that had 10,000 Muslims in it, huge study. And we asked questions about how people, their perception of COVID, what they understood about it, how they were coping with it, mental health considerations, all these different things. And it was so interesting to us that there was the most salient finding, I'll just share with you the most salient finding of the study, which was very interesting to me, showed that people that had more uncertainty tolerance, they were able to tolerate the uncertainty, right, of COVID-19, because the pandemic bring all kinds of uncertainty until today, right? But certainly think about early in the pandemic, tons of uncertainty, what's going to happen. And people who were able to tolerate the uncertainty, which was directly correlated with the faith. People who believed that there's a divine being, there's God, and he's in charge, and that God is the one who sent this pandemic in the first place and will get us out of it. And that kind of thinking, which comes from the Muslim faith tradition in this case, these are Muslim people that are taking this survey. The people that had the higher levels of uncertainty tolerance had lower major depressive disorder. And the opposite was true. If they had higher levels of uncertainty intolerance, they had a likelihood of developing MDD or major depressive disorder by 63%. Like, there was a clear clinical correlation between this resilience and hope that their faith had given them, right, to a mental health condition. This is key when people try to ignore the spiritual aspects of mental health and healing. I point to this study and I say, what would you do with all these people that are really relying on their faith and kind of coming through, and their sense of resilience is coming directly from their faith. And we want to neglect that within our mental health discussions. Right? It's not a popular yet. It's becoming a little more popular than it was, decades ago, but it's still a hard push. And even my own institution, Sandra, it's a very biological institution. Everything has to be seen under that fMRI machine, right? And it's really hard to say, there is a very important piece to the spiritual discussion. But studies like this have really been helping to show that over and over and over again. What we in the faith community and those who are connected to a faith community know to be true anecdotally. Right? So all things, to consider. All right. Now, here we switch into a little bit. I spent a lot of time talking to our faith leaders. I want to spend a little bit of time talking now, or our equal amount of time, I suppose, talking to our mental health clinicians and our faith leaders together. I mean, the next section is really on what we call taboo topics within faith populations. It really depends which faith religion we're talking about. But these are topics that it becomes really important for a mental health clinician to understand that there may be overlaying religious or spiritual aspects to the discussion. And here are some examples, like substance abuse. There are certain faiths and religions that explicitly prohibit recreational drugs completely, right? Or the use of alcohol, like in the example of the Muslim faith tradition, for example. And so when you have a community member, a congregant who is suffering from this, who actually is dealing with substance abuse, there may be a ton of stigma and a ton of shame and guilt as well if they come from a certain faith tradition where they feel they will be judged for what's happening here. And often that will be a barrier from getting help. Domestic abuse is another one. I mean, I would imagine the vast majority, if not all, faith traditions prohibit any form of domestic abuse. Yet there are certain cultural norms that might impact a person's willingness to actually disclose this, right, to a clinician that's not from their same faith background, again, for fear of judgment, but certainly for fear of legal, repercussions, of course, as well. Or they're worried that they will affirm some sort of negative stereotype that's about their religious background. I'll talk about the last two. I'll talk about suicide last. So I'll talk about sexual activity first. And again, many, faith traditions, some prohibit any sort of premarital physical relationships. And there might be, again, stigma against this as well. So talking about this, this is where it's really helpful actually to have a multidiscipline kind of approach to this. Because when it's a very secular frame, and you're kind of doing your checklist as a mental health clinician, you're going through this, any drugs or alcohol, are you in any romantic partnerships, physical partnerships? Are you, have you experienced any domestic violence? Right? It kind of this checklist all the way down. But what it does, what it misses actually is the religious or faith-based nuances of what that question might mean. It might be a lot more loaded, if you will, than somebody who's not from a faith tradition. Now, I promised I would speak a little bit about suicide, and I want to give a trigger warning here because it is a heavy conversation. So if this is a little heavy for you, by all means, please feel free to take a step aside and join us whenever you're able to. Then, many faiths and religions consider committing suicide or attempting suicide to be sinful and taking one's life. And for that reason, there are all these different rules in different faith traditions about, what happens in the aftermath in terms of, is there a prayer? What happens to the burial procedures? Is there, in certain faiths, like for example, the Muslim faith, there's also a washing and a shrouding ceremony that happens, and where exactly the person is buried and how. So there's all these different potential ramifications. The sermon that's given, what is said during it, so on and so forth. And this, and people who've attempted suicide, attempted to take their life, can also be viewed by other members of that congregation as having a weakness of faith, right? Or they might be just much, much more defensive in disclosing it because they come from a tradition in which it is impermissible to attempt to take one's life. And so this is Bempar, I mentioned to you that we have a whole training we've developed in the lab. We spent a number of years writing up a manual on suicide prevention intervention, and postvention. Postvention is what is basically in the crisis aftermath of a suicide. That's specific, these three things, this manual is specific to the Muslim faith community. And our goal actually is to try to extend it beyond this one faith community to actually other faith communities as well, because there's a lot of overlap. But there's also a lot of subtleties and nuance. And what I found working with our Muslim religious leaders, our imams and our, and our there are different terms, ustad, different ranks of, of Muslim religious leaders. It was really, really hard to tell them to take a completely secular-based suicide prevention training, even though there's some excellent gatekeeper trainings out there. But they just felt like it didn't apply for them. They still didn't know what to do with the sermon and the washing and the burial and so on and so on, and how to rectify the theological belief with how to be helpful and compassionate and healing in this aftermath, and to the family and to the friends and to all those who are, dealing with the ripple effect of what may have happened to them. Or even bringing in any programming about suicide prevention. We think this would be a good thing, but for many, they're like, no, we don't even want that here. We don't even want to put this idea in people's minds, right? And what we know, of course, about suicide research is that you never put that idea in their mind. In fact, the more you talk about it and the more you educate it about it, the more prevention that actually happens. That's what we know for sure, that talking about it and having programming in the religious space and outside of it is actually what's preventative, right? And then people know that they can come and talk to you for help and potentially get connected to help, right? And I say all of this because it took a lot of work to custom tailor this to the faith community. And I felt very strongly about this because I wanted to make sure that the faith tradition was accurately represented, that there was scripture within the actual training that was clearly identifiable by our faith leaders who are like, oh yes, that verse in the Quran, okay, gotcha, and that's, that kind of customization is really important. We are lucky enough to be able to be at a research institution where we're now also applying for our IRB, which is our ethics approval, to be able to do testing and make sure that what we're delivering is actually meeting its mark, the pre and post testing of it all. Not to bore you all with the research aspects of the story, but just to explain to you that it takes a lot of work to make sure that this becomes, and a lot of evaluation to make sure it becomes kind of an evidence-based training. And I can speak more to this. In fact, I have a whole talk on this coming up on Friday that I'm happy to share the link to. It's an open talk of Super KT, which is basically a series on suicide prevention research that different suicidologists speak on. And my topic happens to be this Friday, and it's on Muslims and suicide, and the research and the work and the manual and the trainings that we've developed. So happy to share more about this topic. But the reason I went into depth about this topic in particular is because out of the 4 on the screen here and the many more taboo subjects, suicide particularly is one of, I call it the taboo within the taboo, right? It's like a very difficult topic to broach, especially in faith communities, in any community, but especially in faith communities. And so, I think we really need to take some time to really think through this one and know that we can be, our faith leaders can really be major helpers and of course proponents in helping with suicide prevention. I don't have to tell you all here that the rates of suicide are up since COVID has started. And I'm sure you have, as we have, unfortunately experienced in our own community, deaths by suicide that have really gone on the rise. So hopefully that's an important piece to the conversation. All right. Now, a couple more things as we kind of get closer to wrapping up and having our open discussion. Barriers from seeking treatment. These 3 on the screen here are ones I know I've heard quite a bit. I wonder if you have heard them. Certainly feel free to use your emoji there and tell me if you have as well, a thumbs up sign. The congregants really have hard times sometimes with the mental health system because they feel that their belief system is different than the secular system that they're trying to enter into. And their own faith and belief system is not accounted for, right? Also, there's an issue here about looking at any sort of psychopathology, any sort of mental illness as a weakness of character or as a lack of faith. I hear this all the time. That person just needs to pray more. That person isn't a good fill in the blank. Muslim, Christian, Jew, Buddhist, fill in the blank, right? If that person was better connected to their religion, this wouldn't happen. There was a little clip going on social media. I don't know how many are on social media the other day, and I'm sure the preacher was very sincere. Like I don't know that, who knows? I don't know this person. I'm sure he was trying to be very sincere, but he made a statement and he used the word depression. And he said, and that's probably where he went wrong. Like if he had used some other word, maybe it wouldn't have been like this. But he basically said, or what it sounded like to others in his sermon was, what is depression? Depression is when you're far away from God. What happens when a person is disconnected or far away from their loved one? They feel depressed. Now, hearing it from kind of a religious frame, I think you can understand maybe where he was going with this. But for your millennials and your Gen Zs and your other folks who are on social media hearing this, they just threw up a fit and they were in an uproar of, what do you mean depression is a biological condition? How could it be just explained as a distance from God, right? Anyhow, like I said, there's a lot of work for us to do out there, and this rhetoric is actually very common, and it could be very hurtful and even problematic, and sometimes it's completely unintentional. So meeting in the middle, I think, is going to be really important. And the last bucket here is disgust, which is disgusting the medical system, right? Either because of a lack of knowledge, we fear the unknown, we fear what we don't know, right? Or it could be, and if we've never been to therapy, never been to a psychiatrist's office, we don't know what that's all about, so we're kind of scared of it. Or it could be distress, because so many of our communities, unfortunately, have had bad experiences or bad run-ins with the medical establishment, right, or the mental health establishment. Also, for our clinicians here, a couple more things to keep in mind. When you come to understand, faithful families, right? You have to remember that it's not just the individual that you're working with. Mental health, our mental health system is very individual driven. It's like the person in the room. In my trainings, when I teach our Stanford residents and our PsyDs and our MDs and our PhDs, we have different classes, and I kind of teach courses related to culture and religion or diversity and so on. And what I often say to our trainees, I say to them, do not be under the guise or kind of think that it's just you and the patient or you and the client in the room, right? For a person from a faith background, there are invisible members in the room, and that could be their family, right? Because they consult back with their family. It could be their community. It could be their faith leader, and it could also be God, right? Or the divine. It's really important to understand that it's not a one-to-one relationship. That even though that person may be nodding in your room, you say medication, and they nod. They can say therapy, they nod. But then they do none of the above. And it could be because there isn't a buy-in, because there needs to be a larger buy-in from the communal aspect of their faith and their family, right? So really remember this important piece. Interpreters are important, especially with different language settings. Informed consent and confidentiality is key. The reason for this is so many people worry. They know that within their social and even honestly in their congregations, that word gets around. People talk, there's gossip. And as soon as they're identified as having some sort of condition, particularly if it's a stigmatized one, like a mental health condition, they worry about confidentiality. I come to you as the faith leader, or even honestly, the mental health clinician, and I tell you of my fill in the blank trauma, let's say. But is that going to get around, and is my whole community going to know about this? So the issue of confidentiality is so key. Explaining that actually both of our professions, right, all of our professions here are governed by confidentiality, right? And that's really important. The last bit of this is the involuntary commitment. When a person has a serious mental health condition and actually has to be involuntarily committed, maybe on an inpatient psychiatric unit, for example, there's a lot of stigma around this as well, and hesitation. right? And unfortunately, people like really wait, and families do this too. They wait a really long time to finally say, I can't handle this condition anymore. I can't take care of them anymore. And it's like sometimes their condition is so far gone. And in our mental health field, the psychiatric field, we say, the earlier the onset, the earlier we're able to do the treatment, the better the overall outcome. But when it stays on for a very long time, like depression for a very long time, psychosis for a very long time, fill in the blank for a very long time, it's just harder and harder to treat, right? So it becomes really important to talk openly and honestly that maybe a person does need to be hospitalized for a period of time to really kickstart the treatment for them, right? And you can be a really important part of that. And so my last slide here is really some resources that I'd like to talk to you about, and then we'll open up for questions and thoughts that you have. This presentation was largely taken from the American Psychiatric Association's quick reference on mental health for faith leaders. I have here the website. It's psychiatry.org/faith, and it's actually a free downloadable PDF. There's a larger PDF and also a quick reference. There's both, and they're on the APA's website, and you're welcome to access that. For anybody who might ask, can we have access to your slides? It's actually right out of this, majority of it, I should say, not all of it, but majority of it's right out of this link right here. So please do take a look at that. I also appreciate the Caring Clergy project. There's a lot of great tips there on how to make referrals, suicide prevention and intervention, and the link for that is up as well. I spoke today about the Muslim community suicide response that we've been working on in my own, organization that I'm the executive director of in our community, called Meristan. And Meristan takes a lot of the research from my lab, the Stanford Muslim Mental Health Lab, and translates it into trainings and manuals and sermons, actually, even for our Friday congregations and our imams and so on. And so all of this is available on our site, meristan.org. And there's a link there specifically to this Muslim suicide response, and I have the link to that as well up here. But certainly, please welcome Meristan into as the newcomer in town. It's a new organization. We're less than a year old, but I'm very excited for how much progress has been made in actually talking about various mental health conditions in my own faith community, which is the Muslim community. And lastly, we have to, put up NAMI's FaithNet link here because so much great work happens there. And I'm sure many of you here already have that link, but I wanted to make sure I had it added for you. So if you've had a chance to, thank you. I see it's in the chat box. Thank you so much, Kathy, for putting them in there. And here is some of my own information for those who might want to be in touch. You're very much welcome to. We have a lot of information on faith and mental health, in our case, specifically on the Muslim faith tradition and mental health that we put out on our social media sites and our websites, particularly social media. Every couple of days, there's some cool new tidbit about mental health and faith. So if you happen to be on social media, then these might be cool, channels to follow. And with that, I'll open it up for any questions we might have. Thanks so much.
Dr.
Go
Watt,
ahead, Wes. Go ahead, Wes.
I was wondering if you can send a printout of your PowerPoint presentation, your particular one. I know you mentioned it was in one of your.
Yeah, I can download a PDF of this. If this isn't a PowerPoint, it's a different system, but I think it allows me to print or send out a PDF version of it. Yes.
Oh, I'd love that. It's so good. Thank you.
Sure thing.
So, Dr. Awad, we definitely want to thank you, but we want to take questions. I was looking in the chat. I didn't see any unless I missed them. But if you have a question, go ahead, unmute yourself and ask Dr. Awad the question. Is that all right, Dr. Awad?
Of course. Yes, absolutely. Sylvia?
Okay.
Assalamu alaikum, Dr. Waz. How are you?
Walaikum salam. Well, thank you.
Yes, good. So I'm a long-time follower, and I really appreciate all the work that you're doing. I'm a Muslim chaplain currently out of New York, and I come across a lot of scenarios that you've explained within our Muslim communities. And my question actually to you, and I follow your work a lot, and I refer to it a lot within my realm of work. How well do you think that the knowledge that we have, we live in the world of super knowledge, basically. There's a lot of information, there's a lot. How do you simplify it for, let's say, like you said, you were dealing with a lot of faith leaders and community leaders and things like that. But how do you simplify mental health for them in a sense where it's less intimidating because of the knowledge that's so much out there, and, the technicalities and things like I run into that a little bit, just to simplify it, that, again, it's that same question that circles around a lot with us whenever we talk about mental health, is how to normalize it being part of our health. Like, that's just the question that, however many times we answer it and question it, it still lingers, basically, unfortunately. So I would love your take on it. Jazakallah. Assalamu alaikum.
Thanks, Sylvia. Yeah, it is. I love what you said there. Super knowledge, I think you said. It's pretty cool. Yes, there's a lot of information out there, and it is hard sometimes to really but I think I heard two questions really embedded within your question, which is one about how do you condense the knowledge and make it simple enough for people to understand, especially complicated mental health things. And then there was a bit of a second question of like, how do you explain that this is in fact a mental health condition, a medical even condition. Right?
Yes, medical, yes.
Beyond just the spiritual. And so a couple of thoughts for you. On the same link that I gave for the APA site, they also have a handbook. It's kind of a simplified handbook, if you will, of explaining mental health conditions that I thought was very useful, full of tables that were really helpful. But good news for you as well, since you're a chaplain within the Muslim community, our lab has been working on, it's been a bit of a project, all of our projects. I like them to be like super evidence-based and super, in place before we release them. But we have a product that we're working on that are pamphlets. They're a series of mental health pamphlets explained to the Muslim faith community. And what we do is we tie in, kind of very similar to our suicide response training, we tie in all the medical psychiatric understandings of different conditions, depression, anxiety, PTSD, so on and so forth, OCD, so on and so forth. And then also explain kind of the faith-based or Islamic understanding as well, because there's a very rich tradition and legacy within at least the Muslim faith on mental illness, actually. For those who may not know here, even the name of our organization, Meristan, is in reference to the original hospitals. They were called Meristans in kind of Islamic heritage and legacy. And to our knowledge and our research, they're the first in human history that actually had a psychiatric or mental health ward within the hospital system. The first civilization that actually had psychiatric mental health systems within their hospital and healing treatment centers. And you can actually still visit some of these today. They're fascinating. And so they're called Meristans, and get very passionate. Probably could speak a whole hour on this, but I will not diverge too much. And to say that what we do in these pamphlets I'm referring to, Chaplain Sylvia, is we talk about the Muslim kind of tradition, legacy of understanding of mental illness, the spiritual aspects, along with the medical psychiatric aspects, so that they're side by side in a simplified pamphlet. And it's a series of pamphlets, if you can imagine, like in a doctor's office or in a therapist's office or somewhere where you have like different pamphlets you can take from. So it's a product that we hope to release sometime in the very near future. And maybe those are ones that you and your chaplaincy can actually give out to help explain to folks.
Wes, you have your hand up?
You. In your presentation on suicide on Friday, I'd like to participate in that. I recently had a suicide in jail 3 weeks ago, where I signed a Christian minister to the inmate, and he committed suicide about 3 weeks ago. And I like the idea of I really won't want to hear your points on post-suicide counseling, people who are involved. Who would you involve? And there are guards, there are inmates, there are people, our families, but so what are your thoughts about that?
Yeah, definitely. The postvention part, actually, out of all the three, prevention, intervention, postvention, I actually find the postvention one to be the most complicated, actually, because this is an aftermath. It's not a theoretical. It has actually happened, and so many people are affected. Sometimes the most affected are people we don't even know. They're silent, right?
Mhm.
And so we've developed this approach that we talk about in our manual, and I probably will speak about more in detail on Friday. Of it's an approach of healing, community healing. After, so in the case of the jail that you're mentioning, it's the whole, that's a community in itself, and we have different breakout healing groups. There's a very short and concise presentation that happens from the faith leader, from the clinician, and from the therapist. Kind of, we very specifically have a model where we do that, and then we have people kind of break out into healing spaces in order to discuss and kind of process what's happened. And yes, I do, in short, I do think it's important that all the different people who may have been affected are at least invited. They may not want to come, but they can at least be invited to those healing process circles. We have found in a faith community model, and kind of transfer this now to a, like say, like a mosque or church or a temple setting, it's been very effective. And we have a further model where we kind of, if there's youth involved, we kind of break them up by different ages and the people that were closest to the person who's deceased versus those who are a little further out. We've tried it, we've piloted it essentially in multiple different communities, and it's had a pretty good response, I would say. It just takes a lot of thoughtful planning, and also very careful, concise language that's used so it doesn't trigger accidentally anybody else who also may be feeling vulnerable within that group, community, congregation.
Have you done it virtually?
So the one in March will be the first time we do this virtually, and yeah, we'll see how that goes. Usually these are done in person because they were always pre-COVID, but now that we're in this era, we're going to be trialing this in a virtual setting.
Okay, thank you.
Michael Jones, you have your hand up.
Thank you. Dr. Wad, first, thank you very much for your presentation. Very informative. There's another intersection of people that I wonder about in terms of culture, faith, and then LGBTQ community that come in, and quite frequently they get pushed into there must be something wrong with them. Let's send them to the psychiatrist. Let's send them to the mental health professional so we can cure them. How do your practices treat this? How do they react to this? Are there specific programs to address that set of issues?
So that's actually a really good question. And yes, I've seen exactly what you described here, that same phenomenon of like, there must be something wrong here, let's push them to mental health. And interestingly enough, many people who are from that community really feel that there's more reception to even hearing and helping within the mental health space as opposed to faith communities. So honestly, I guess the most important thing I can say is there's still a lot of work ahead of us for inclusivity and making people feel that they can come to us as they are, like whatever it is that's happening in their life, whatever background, whatever walk of life, whatever, situation, that's the case. And so I haven't seen a specific program. What I've seen are more like identity-based clinics and programs that have been useful, like clinical programs that have been for LGBTQ identified folks. And there are elements of faith and spirituality that enter into that. I haven't seen a full kind of reception on the other side, though, to be honest with you. And I think there's just a lot more work that needs to happen.
Thank you.
Yeah.
So I have a question, Dr. Awad. I'm going to ask it for the clinicians that might be present. If I'm a clinician and a client comes to me and eventually we start talking and they bring up certain spiritual concerns and so on, I don't feel comfortable particularly talking about it because it was never a part of my training going back years and years. And in fact, we were told not to do that. So I'm trying to learn and to understand, what would you say to me And how would I go about assisting this client and helping them to explore their understanding of their spirituality and perhaps religious. And then as a kind of addendum to that, or a part of it, particularly if it's a religious question that comes up and I happen to be Christian, and say somebody from the Jewish faith, I was talking to somebody who was of the Jewish faith, what would I do? Do you have some thoughts about that?
So the question is about for different faith, or kind of the mental health piece of it?
Well, I think more just let's take because a lot of times clinicians come to me and they say, Bill, I don't know what to do. I don't know what to say. I don't know what language to use around helping them to explore their spirituality. That comes up a lot. What do I say to them?
Well, I definitely think that we have this term in the field that we call a cultural consultation. Now, I realize that every faith considers themselves also a culture, and so it may be this bit of a misnomer for some folks, but the concept is the same. It's a cultural, or maybe you can call it a religious consultation with faith leaders. I've personally found that very, very useful, where I've looped in a person's faith leader into the discussion. They didn't have a whole lot necessarily on the mental health front, and the clinician didn't have a whole lot on the faith front, but together as a team, they really, really were able to help the patient or the client that's seeking out help. And until that partnership happened, it wasn't like a full treatment plan, that was really in place. Mm-hmm. I think a lot of people don't know how to reach out. The last organization I was part of, just to give an example, within the Muslim faith community, and I'm sure we're going to do this again now that, with Meristan, we're kind of starting up all the services, even therapeutic services. We had something called religious consultations, where you can literally click on the website and request a religious consultation from faith leaders who felt more connected to the mental health, or maybe they had dual training like myself, or maybe they were folks who had taken some certifications in mental health background. And because of that, they felt more, or maybe a master's level degree in psychology or something like that, where they felt more attuned to mental health and yet had full religious credentials, and were really, really helpful in untangling certain aspects. Even in therapy, honestly, there are certain things that come up in therapy that a clinician will say, I don't know heads or tails of this. Like, things come up in marriage family therapy, for example, related to marriage, divorce, child custody, and so on. That's like, there is a legal aspect, but there's also a faith-based, especially if there's like a ritual law aspect to this, that the clinician's like, I'm lost, I don't know what to do. And that's really useful to have a religious consultation help untangle some of that.
Thank you. Marianne, you were next with your question.
Hey, so I had a question in terms of, like, one about suicide. Is it a smart thing to, if a family can cover up the fact that their child committed suicide, is that beneficial to the community? Because I've heard, like, there's a spiral effect where if someone commits suicide in a community, where like it could lead to other suicides. So that was my first question. And my second question is, if there's a death in the community, let's say it's a young person, is there supposed to be healing for the whole community in general? Should there be sessions or something like that, like you were saying about the whole suicide thing? Is that also supposed to be something like that as well, if there's like a sudden death for a young person within the community? Thank you.
Thank you, Mary. The second part of the question is, should people, I think you're trying to say, like, assume, not assume that it's a suicide? Is that what you mean?
No, like, so let's say it's a regular death, but it's like a young person dying in the community, right? So there's like, so we had this in the community where like a young person died who was like 21, and if that person's a young person, there's a, like, it's much more, it's like there's this huge shock to the community. Mm-hmm. And if it's not a suicide, should there be like a healing session for the community? Is there anything like that? Would you recommend? Yeah, just, if it's a normal, yeah.
I'll answer your second one first. It's a little bit quicker. It's definitely there should be, especially anytime there's something that kind of has a kind of there's a bit of a shock, right, to the system, or kind of a bit of a, like, I'm trying to grapple with what this means, especially when it comes to things like, why do good things happen to bad people? That kind of, theological, faith-based questioning that happens. I think it's very useful to have healing circles circles and spaces. One thing I didn't mention, and thank you for bringing it up, at Maristan, we actually have these monthly healing circles that are free and open to the whole community. They're not therapy sessions, but they're healing circles. And often they're about various difficult things that are happening. Sometimes it's like this news of a death of a community member that's very sudden and unexpected. Sometimes they're global world news, right? Issues that are happening, or there's some sort of, attack, or sometimes there is a commemoration. Like this month, we have one about, Black Muslim experiences concerning its, African American History Month, and so on. There's the hijab ban in India that's just come up that's causing a lot of people in our community in uproar. So there's one about that, coming up as well. Anyway, the reason I say that, I think healing circles are really important and it's very helpful. And we often try to have a variety of representation. So it's spiritual, mental health, and maybe a content expert, at this healing circle. The first part of your question, that is, so that's a model that folks like. There's a link on our website at Maristan to learn more about the healing circles. Now, the first part of your question, Miriam, that related to what we call the contagion effect of suicide. It's basically the fact that people who, if there's a death by suicide and it's highly publicized, and there's just a lot of like a rumor mill that's happening around it, there's what we worry about, especially in our field and in public health crisis, is a contagion effect. It's exactly what it sounds like, contagious. Unfortunately, people, especially young people, we see this quite often. Anybody who's already vulnerable to suicide may actually then take their life, and it becomes like a ripple effect or a domino effect. And so to answer your question, there are two parts of this. When a death by suicide happens, part of the work in post-vention is exactly what you said. We do not romanticize, we do not make a big fuss about this. There's all these media guidelines now for reporting and journalism to be very careful of the language they use and to not give details of how the death actually happened. They don't actually, they should know. It's not proper journalism to actually say what exactly happened. They just could refer to it as a death by suicide. Because all of these things could be very triggering to the person in the room or the person reading this article, and you don't know who's receiving that on the other end. So there's really important post-vention guidelines. We actually have an article, I can actually put it up for you, something we wrote. It was for the Muslim community, but if it's useful, some of it I think is, even for other faith communities can be useful as well. I'll try to find the link in just a moment here. But yes, you have to be very careful. And so we have the training I was mentioning about clergy members to be careful of how they say and what they say, so it's not further triggering, even though they're really just trying to help, honestly, the situation. Now, what I don't agree with, just to wrap up my last thought here, what I don't agree with is hiding this, is making believe like it didn't happen. We have this term of brushing it under the mosque's rug, you know what I mean? And so on for other faith groups too. Because ultimately, there are folks in the community who know or will guess that this is likely a death by suicide. And the less that it's talked about, the more mystery that kind of shrouds it, the more problematic actually this is overall. So I do hope, as we think through how better to address it, I have here the link I put. It was, like I mentioned, it was specific to this specific Muslim faith community, but some of it's very much extendable to other faiths as well. And we have this chart you can see as you go down into the article of what do you say in the aftermath of a suicide and what do you not say, right? And it's inspired by the Muslim faith tradition here, so it may not apply to every faith tradition, but we also gave tips, 10 aspects of how do you respond as a community in the aftermath of a suicide. Hopefully that's useful to folks.
Unfortunately, Dr. Awad, we need to bring this to a close. If there's anything you want to say in closing, we would welcome that, but we just want to let you know how grateful we are that you took the time today, because we know you have an incredibly busy schedule and that you do work all over the world, really. And so thank you for your time, sharing your talents and your knowledge, and truly, it's been a very rich and rewarding experience, I believe, for all of us. But if you would like to say any closing remarks, we would welcome them.
Thank you so much. It's really just a word of thanks to everybody here for your attention. I do hope this has been of use. I'm always open to feedback. That's probably what I would ask and say in closing here, and just further networks and partnerships with all of you and your different congregations and practices. Hopefully happy to be of service and be in touch. Thanks so much again.
With the degree has been taught for years to never talk about spirituality, and the new refreshing look at how we interpret it is good and healthy. And as if from the faith leader's point of view, how the unspoken taboo is to be part of your conversation, because the faith leaders are the first line of defense, and a lot of the people, their first contact when they realize they are facing mental issues is to a faith leader. In terms of what tools, one person shared that they have used within the spiritual teaching to practice and find inner acceptance and peace, and that contributed tremendously in dealing with PTSD. And another person shared that after a traumatic incident, that they realized through the experience that God's love is all around.
Thank you, Helen. Group 2, who was in charge of group 2?
Wesley, you're muted.
Is that our group?
Kathy, was it which is my group? Which is my group? Group 2?
Wes, you're in group 2.
Okay, Jairo, would you like to report out?
Yes. So let's see about question 1. We actually, two of us really thought about what the presenter talked about, the care after somebody completes suicide. The post-suicide care that is so important and so often, at least for the two of us that talked about this, something that we were not very knowledgeable about, and that we didn't get a chance to, that we would like to learn more about, because we were not very knowledgeable, and we wanted to learn more about how to do this. We also talked about a curiosity. One of us thought that the 4 things that the presenter mentioned were curiosity, openness, transcendence, and love, and how she spoke about all of those 4 aspects as needed components of the work that she was doing. And also, there were thoughts about how we bridge the gap between the 2 worlds of the clinical world and the faith world. So we have that role of bridging the gaps. That was for question number 1. For question number 2, I think we talked a lot about, one of us talked about the importance of protecting themselves from burnout using spirituality. Some other of us spoke about our own personal recovery. I know that I disclosed that I'm in recovery for substance abuse and for behavioral health condition, and that according to the model of recovery that we have, a life lived through spiritual principles looks very similar to a life in recovery, right? We spoke about hope, the importance of hope, and the importance of moving in life towards either a healthier life or a wiser life. And I think that was that.
Okay.
And I think that's perfect because now I have to leave you guys. I'm so sorry. I wish I could stay. Such a great time.
Thanks for coming, Jairo. Thank you for coming.
Thank you, all of you.
Thank you, Jairo. Good to see you again.
Good to see all of you. Bye-bye.
Group 3?
So I think
was-
Kathleen was taking notes for us. I think she's going to type them.
Okay.
I don't know
So-
if she's.
Okay, I'm so sorry. My computer rebooted. I got a 1-minute warning and I made Andrew Nami Santa Clara the host. So are you done with your discussion?
Yeah, well, we're at group 3, and someone said you were the recorder for group 3.
No, I
You
wasn't
weren't?
in any of the groups. Group 3 is
Oh.
Anna's group.
Okay, Anna?
So for number 1, we talked about that the journalism, like the rules for reporting on suicide, and like obviously you don't romanticize it. Sorry, and then they don't want to write something that would trigger other people, and it's important to note how priests. We talked about how it's good to know that like sometimes people with a religious background might unintentionally say something or do something that's triggering to someone, and it's not intentional. It's a lack of understanding of mental health, and those were what we had for the number 1, and then number 2 we had a little bit more to write that we wrote about. So sometimes we talked about when like working in a mental health capacity with spirituality, the importance of integrating as long as the client allows for that within the practice of serving with someone. And then sometimes we talked about how some people specifically bring up like, I want religion to be included in this conversation with mental health and spirituality. And then we talked about like practices when sometimes people will say something like, I think like I'm sick because God made me sick, but it also helps me better understand other people's circumstances, and then like where to focus the conversation on. Do you focus on the first part or the second part? And then depending on the severity of the conversation, sometimes you'll focus on one more than the other. But try to focus on compassion versus like a negative stance. And then we talked about faith ministry in jails for spirituality and faith. It's important to find clients' spirituality because sometimes coping skills and functioning skills are important, but also there's the aspect of like grounding the self and building a strong basis of a spiritual sense of self and meaning in life to help with recovery in that. And then we talked about like a Buddhist change in perspective, how sometimes asking someone when they're talking about their mental health depends on the situation. Like sometimes you have to ask very open-ended questions and just acknowledge the person's point of suffering. But if you're close with the person, then sometimes you can ask certain questions that maybe you wouldn't ask someone in a different setting and see if they're open to other possibilities of like, today we understand you might feel like this, but is there a possibility that there's something else going on? But you would have to have that close relationship with that person. You couldn't just ask like someone that you just met for the first day some of these questions. And I think that was it. Anna, did I miss anything? Was it okay? Okay. I think that was maybe it then.
You're on mute,
Thank you,
Anna.
Brandon. So group
I
4.
was just saying that was the summary was very good, very
Okay.
comprehensive. Thank you.
Group
Yeah.
4.
That's
Ann, that
Ann's
would have been
group.
your group.
And you're on mute, Ann.
I'm on mute because I wasn't going to answer. So maybe Sophia, could you summarize it well?
Okay, I'll try. So we were actually talking about, again, making the connection between the spirituality, reaching out to the, spiritual leader, depending on being open, and reaching out to the professionals who are clinicals to really reach out to the faith leaders. That was a new term for us, right? So reaching out and having to look through that avenue as an option for us to be able to, merge the both, which is the spiritual and the mental space, basically, for the betterment of the client and whoever we're serving, basically there. And the takeaway really was about the suicide, that we definitely should be having more conversation. And one thing we talked about in our group was that how we're supposed to differentiate the act of the suicide and separate that from the person, and building the sensitivity towards that, basically. So that was our discussion.
One thing that I would like to add is that two of our people could not do audio or video, so they could hear us, but so we use the chat to get some conversation going. But I would also like to say about both of them, they are both people sound like they're new to the field, relatively new, and how nice it is that they're starting off on the right foot really early. So thank you.
Thank you, Group 4. So I think we're ready to move on to the next two questions. I don't think we need to take any more breaks. I think I'd rather just go on because it's now 11:32 and we need to be finished by 12 o'clock. So we'll take another 19-20 minutes to go into our next group. I will read the questions and then I've got them ready to put into the chat. The next two questions that groups will answer, the first one is, given differences in spirituality, faith, and religion, how would you approach suicidal ideation / attempts or mental health concerns? Second question, what have you observed when behavioral health and faith communities attempt to work together? And I just put them into the for you.
I have a suggestion. Since we don't have that many people, do you think we can, instead of doing the breakout room?
Sure. You mean just do it together now?
Thoughts on that?
Sure.
Yeah, because then we don't need to, go to the group and then report. It's probably.
Okay, that's a good idea. So, Anna, so that's fine. And there's a few other thumbs up I see. So
I'll keep recording. I'll keep recording now.
Sure, please do.
We're all together. We don't need Andrew to describe it, I guess, right?
No. So given differences in spirituality, faith, religion, how would you approach suicide ideation / attempts or mental health concerns?
I think I can go. I can start the conversation.
Sure. Go ahead.
I sometimes, given my Christian background, suicide is a sin. And so I try to help my clients to not normalize it, but understand it, kind of separate it from the faith perspective and from the clinical perspective. And as so I would tell the client that the thought of suicide, sometimes it doesn't come from them for the most part, right? It comes from the illness itself. That's part of the symptoms. And that comes, and so I ask them something like, is it really come from you or is it come from the illness, right? And then they'll tell me whether it's coming from, the majority of the time they'll say, it doesn't really come from me. It does come, right? So I separate the two to help them feel like this is not really their intention. However, it is there. And how do we work together to cope with that symptoms? So I rephrase it that because that's what it is when the chemical imbalance it triggers these kind of thoughts, the thoughts of hopelessness, the fact that the suicide ideation comes from mostly hopelessness, and hopelessness is actually comes from the illness itself. So I'm trying to explain some psychoeducation with the client first before I even touch the religion part of it, the set of beliefs part of it.
Thank you, Anna. Go ahead, Wes.
Well, I'd like to hear from someone else. Go ahead.
Okay.
I'll come in later.
Someone, I think Pinky just
Pinky,
posted
right.
in the chat.
Yeah, she doesn't have a microphone. I'll read it. If the person is spiritual or religious, it would be helpful to utilize their beliefs to remind them of where the standing is for their particular religion on that topic. I tend not to use that unless I feel it is helpful for the client. And they mention to me that they are faith-based. And then the second part of her statement is, I have noticed from a client that that she is with her religious community, which is Mormon, that her spirituality is reduced. I think that's what you were saying, Pinky. Did I get that correct? That last part. So Pinky says that the only her suicide ideation is reduced. Got you. Sorry. Thank you.
Okay, I'll say something.
Go ahead.
All right. Well, I'm going to speak from a chaplain's point of view. And I think anyone in the community's point of view is, even though you're not a mental health clinician, is that, and then this is what we were taught, you know, I would directly, if somebody says I'm feeling suicidal, then I would take it further. And I think that's what Dr. Awad suggested. I would say, are you thinking of killing yourself? I would be very straightforward with them. And if they said, yes, I have, then I have to go further. How would you do it? You know, and if they say, I have some pills, or I have a gun, or I have something like that, then I would be very concerned, and I would then consult. And I think I would consult with someone if they're very serious about that. I would consult with Suicide and Crisis, and well, I would also, you know, think of having that person involuntarily committed, because that it is so imminent. That's how urgent it can be. But if they start saying, well, I'm not sure, no, I'm not, you know, I go back and forth, then I would continue with that. But then I would then think of referring that to a mental health clinician, and try to find, you know, where a clinician would be able to counsel and connect with someone. You know, I was one who was a clinician who never wanted, I always thought of separation of church and state, and I would never want to go into that. But and Dr. Awad talked about the boundaries. You don't leave your boundaries, you know, from one lane to another. So I understand how clinicians may feel about that as well, and they would like to. But I think from a Buddhist point of view, and from the Eastern point of view, it is not a sin. We don't have sin. So, but years ago, suicide was a crime. If you can recall, it used to be a crime. So, I can see how the culture is reluctantly wanting to talk openly about suicide. They could go to jail. But I mean, then there's the religious point of it. It's a sin. But in Buddhism, it's not a sin. And however, in most countries, in a lot of countries, indigenous countries, it's a way of saving face, you know. And it could be a gesture of honor because they have shamed their community. So I think we have to look at all those aspects of it.
Thank you, Wes. Anyone else?
I just kind of to tie in with what the point that one of the points that Wes is making is that I think it's very important that we be aware of our own, whether we're a faith leader or a clinician, of what our own bias or what our own thoughts are about suicide. You know, Wes made the comment that it's in Eastern tradition is not considered a sin. There is no sin. I just recently worked with a man, and I've shared with some other people that he's 92. His wife had died a number of years ago. He was extremely lonely. Was he depressed? Yes, but was he clinically depressed? No, he was related to the situation, and he wanted to do the Death with Dignity Act, the EOLA, End of Life Act, and I think that for me, that was a real learning experience because first of all, I came from the Catholic background of such a long time that it was a sin, that it was wrong. And now I'm in the Buddhist, which is not so much about sin, but for me, it's the person's decision and are they capable of making that decision? And that's important. I think I don't think I could commit suicide either by choice or, you know, because I was upset. But I guess what I'm addressing is that we too have to look at what our attitude about suicidality is. And as a therapist a long time ago, I used to make contracts with people when they were suicidal. You know, will you talk to me before you do something? You know, and again, if they were in the place that they could make that agreement, then it could be honored. If there was a place that they couldn't, then you know, then I would call the police and have them do a commitment. But anyway, I'll shut up now. So.
No, thank you, Anne. Thank you. Anyone else want to respond to this question?
I want to say that the question is a little bit challenging to answer because of it has the suicidal and the mental health concerns. And I think I would have a different approach for each one of them. For the suicide, I would focus primarily on safety, right? And it's so in the moment that it's hard to bring up spirituality in that moment when you don't know the person and you don't know if you're going to bring something up. Like, you know, what we talked about, you know, maybe their religion thinks of suicide as a sin, right? And that might be more triggering for them. So I would focus primarily on safety and just meeting the person where they're at. And when it comes more to mental health concerns, that's where I would bring more of that spirituality piece, right? If they're in a safe place internally and externally to talk about religion or spirituality or their spiritual needs and you know, kind of going with what Dr. I forgot her name and I can't say what said about being curious and listening to the person and what their needs are, especially because they know themselves better than anybody else and they know themselves in terms of their spiritual needs, right? And what they, you know, tend to incline towards. So I think that's how I would approach that question.
Thank you. Anyone else want to respond to this question on suicide ideation?
I would just like to add, the actual suicide is a very, very, it takes a lot of energy to do it, whatever it may be. You take a pill, or you take a lot of pills, or you hang. That transition to actual suicide is very difficult. And if someone has the energy to do that, then one must be concerned if there are actual thoughts of doing it. And then secondly, if you feel that, I think it's important for you to make a report. I think that, but it does take a lot of energy. And usually when people do suicide, they have a lot of energy. If they're very, very depressed, they don't have the energy to do that. So I think those are things that faith-based leaders need to know.
I think I lost about the question. One part of the question is about suicidal ideation, right? What is the second part of the question?
I'll read it again. Given differences in our spirituality, faith, religion, how would you approach suicide ideation attempts or mental health concerns? Is that the part, Peggy, you were thinking that, or just mental health concerns?
No, I just didn't remember what is the question. So I think I can jump in on that because I attempted suicide before. Around 6-7 years ago. Yeah, around 6 years ago. Yeah, 6-7 years ago. Around 6 years ago. And I'm a Christian. I'm a Christian for the last 30-something years. So when I actually attempted suicide, of course, there's something that will cause me to end up doing it. And yeah, it is it could be some kind of impulse, but at the same time, it takes some thought. It's not just that, okay, now I want to die, I die right away. It takes some thought for yourself to think, how am I going to die? I actually search online to search which way I would die, not as painful as possible. Yeah, so it takes a thought in my mind before I actually add on to it. But the other part is I have mental illness. So I think that was the major reason that caused me, because I found no way out. Suicide was the only way that I can find way out. And for the spiritual part, at that time when I was too much bothered by all this, that caused me to believe that is the only solution for me. It doesn't matter to me anymore, because it's just too much that a human being can handle. Up to a point that I know suicide is a sin for my belief, but it was too much for me to handle. Even though I know that it's a sin, I wouldn't even think too much about it because I couldn't find another solution anyway. It was like for a very long time that was happening to me that caused me to finally make that decision. So but I think God is faithful. God is very good. God is very loving. So after I attempt suicide and after I was safe, it reminds me of God's love. It wasn't something that I hadn't experienced before. I had experienced tons of God's love in the past and experiencing Him in my personal life, in my spiritual journey. So it wasn't something new to me. But after I was safe, it reminds me one more time how much God loves me and how much He helped me to go through my journey of recovery. And all this little detail, how He helped me with the financial bill to pay for the hospital bill after I was safe. I stayed in the hospital for like 2 weeks. And so it's just everything that He has done to me that really demonstrate to me how much He loves me. Even though in the midst of my darkness, He is still with me. It's just at that time I didn't see Him because it was just too much to me at that time to handle. Yeah, He never left me, even though at the time that I attempted suicide, He was by my side. So He was carrying me through for the whole journey until I recover. I'm basically recovered from my mental illness. So yeah, glory to God. That's all I say.
Thank you. Thank you so much. Thank you so much.
Yes.
Thank you.
Thank you, Peggy, for sharing your personal
so
experience in such a way.
You're welcome. Thank you for listening and giving me a platform to share.
Thank you.
Yeah.
So appropriate.
So we have about 8 minutes left, or 7 minutes left. Why don't we, I'll put the second question in the chat there again and read it. And if anybody would like to care to respond to it, what have you observed when behavioral health and faith communities attempt to work together? What is your observation when you've seen the two try to come together?
There could be positives and negatives.
That's right.
So
I can share part of my part of my journey. I guess answer now. Anyway, some years ago, I went through my, I guess what we would call spiritual crisis, like spiritual emergence, or spiritual emergencies, and from the outset, it looked like I have a mental health crisis. But internally, I knew it was more of a spiritual crisis, because in the midst of the crisis, I felt the peace. However, at that moment, it is a crisis from outside looking in. So I went to the priest, to the pastor, priest at my church, and he told me that, it sounds like it's a mental health crisis. Maybe it's good for you to go seek some help from a psychologist. I was thankful that he talked about mental health and referred me to a psychologist. However, I wish that he would kind of do a little more hand-holding. Basically, he gave me that suggestion, and I was supposed to find things on my own. So I think it would be helpful if I find if the priest have a list of people that, here are the list that the people that we normally work with. You might want to check it out to see whether, have a little more, have like a conversation versus like, oh, it sounds like you have this, why don't you go this, like that. So from that experience, it's now that I work with clients or I work with other people from my faith communities, I do a little bit of more hand-holding, although I allow them to lead.
I want to add to that, and I have not seen a lot of community and faith and mental health try to work together. From my own personal experience. And as Anna was talking, it reminded me of a situation where I was in a crisis and I went to, I was raised Catholic and went to ask for help. And unfortunately, the priest just said, go pray, and didn't have the resources. And just to be more explicit, I was reporting abuse. I was a child reporting abuse, and I didn't get that help or support that I needed. And I wish I would have, like Anna said, more of that hand holding, more of that, like, walking you through it. And because you go and ask for help for a reason, right? And it's true that spiritual leaders are like, they're the first front of defense. They are the gatekeepers. And I felt like in that precise moment for me, the door was closed. And I wasn't, I got a different message. So I wish there was more of that integration between mental health and faith. And so people don't have to go through that situation again.
Thank you, Nellie, very much. I want to just share a positive situation. Being in San Mateo County as a part of the co-chair of the Spirituality Initiative for many years, we developed a relationship with Peninsula Temple Shalom, a Jewish temple in San Mateo County, and they started coming to our spirituality initiative meetings. So it gave us an opportunity to talk to people of faith in their community, and they developed a whole program because they had a young person who did die by suicide, in their congregation, which was a shock to them. So they knew that they had to do something. It was an unfortunate situation, but out of that, they developed a group, and they now make presentations on a quarterly basis throughout the community. They have attended different trainings. Both their clergy and the congregants have attended different trainings. And they've worked with us around doing presentations as well. Our spiritual initiative in San Mateo County. So that was I would consider a very positive situation that occurred that came out in our county, the county that I work in. Someone else was starting to say something, I think, Wes, was that you? Okay. We're going to have to, we've got 4 minutes left. So we got one more, you've got 1 minute before we do our
You're
wrap up.
muted, Wes.
You're still muted, Wes.
Can you hear
Okay.
me? As a jail chaplain, I receive a lot of people who come because they're disillusioned with their faith and they're looking for meaning. And I think what is important in spirituality is meaning to their lives. And I do it from a Buddhist perspective, but also as a community member. I have tried to refer to mental health, and you have to go through a lot. Well, this is government, county mental health, and I've had a lot of difficulties going through the hoops. At one point, when I was with Red Cross, I tried to refer to mental health, and the person had to call himself, and he had to wait 6 weeks before he got counseling. So we've made some changes in mental health, but I think we need to shorten that bridge. And I have had some good conversations with faith-based leaders as well about how they do it. So yeah, I think there's a myriad of differences trying to bring them together, and we have to bridge that. And I would also say this is just the beginning. I think we'd like to have more discussions in the next year.
Well, I just want to say in closing, thanks to everybody for being here. Today was a very enriching day for me.